Good evening. I'm Susan Ward, a Family Heart Ambassador. I'm also a National Board Certified Health and Wellness Coach and Certified Lifestyle Coach for the CDC National Diabetes Program. And I'm here tonight to continue our wonderful series on empowering all of us who have lipoprotein little a. And tonight we have a really exciting guest, and I want to say that this is one of the topics that was requested by many people at the beginning of this year, and we're finally able to have our wonderful guest speaker, Dr. Ijeoma Isiadinso. So I'm going to move into some of the little housekeeping things. You are in a webinar. Please feel free to put your location, anything you want to share in the chat, and all your questions in the chat. We will get to them at the end. So tonight's meeting, the title is Cardiovascular Disease Risk in Women, Navigating High LP little a, Menopause, and Hormone Replacement Therapy with our featured guest, who is a preventive cardiologist. And she has a dual certification as a medical doctor and a master's in public health. I do want to take a moment to thank the sponsors of our events, and the Family Heart Foundation is very grateful to acknowledge the generous support of these sponsors for the 2025 LPA Community Activation Program and LPA Awareness Day. And those sponsors are Lilly and Novartis. I do want to read a brief medical disclaimer that today's program is informational and educational in purpose only. The content is not a substitute for professional advice, diagnosis, or treatment, nor does your participation constitute a medical or coaching relationship with the presenters or employees or officers of the Family Heart Foundation. Future research may impact today's presentation, and information may be updated or changed in subsequent presentations. Please follow up with your medical professional for specific recommendations pertaining to your or your family member's diagnosis or treatment. And please reach out to a Family Heart Foundation care navigation specialist for further resources. Our featured guest, Dr. Ijeoma Isiadinso, is a preventive cardiologist and associate professor of medicine in the Division of Cardiology at Emory University School of Medicine. She's been a medical director at the Emory Center for Heart Disease, and she has served as the director of the Emory Women's Heart Center screening clinics at Decatur and Lithonia. She has a dual degree in medicine and public health, and she completed her internal medicine residency and cardiology fellowship at Temple University Hospital, where she served as chief fellow in her final year. She serves on several national and regional committees, including the American College of Cardiology, the American Society of Preventive Cardiology, and the American Heart Association. She is a co-chair and co-organizer of the Familial Hypercholesterolemia National Awareness Campaign with the Association of Black Cardiologists, and has served as co-chair of both the Prevention Committee for the ABC and the ASPC Women in Preventive Cardiology Workshop. I'd like to say that Dr. Isiadinso is passionate about preventing heart disease with special clinical interest in the management of complex lipid disorders, cardiovascular disease in women, and cardiovascular risk reduction in patients with systemic inflammatory conditions. And it is my great honor and privilege to allow this wonderful seminar to take place. And Dr. Isiadinso, I'm going to stop sharing my screen so you can share yours.
Thank you, Susan. So as I pull up my slides, I first want to thank you and the Family Heart Foundation for inviting me to give this talk. This is a very important topic for women and for those who are transitioning later in life into the menopausal stage of life. And so I'm not surprised that this was a highly requested topic for your group, and I'm ready to dive into it and see what we can cover and hopefully answer some questions from the audience. So, as you heard from Susan, I am a preventative cardiologist. At Emory, I have no relevant disclosures related to this particular talk. So, I wanted to start first with some general background. Cardiovascular disease remains the leading cause of morbidity and mortality for women in the United States and worldwide. You may be surprised to know that 1 in 3 women die from cardiovascular disease, and 45% of women over the age of 20 have some form of cardiovascular disease. Well, we know what some of the risk factors for cardiovascular disease are, and excuse me, you may have heard of them or be familiar with them, such as high cholesterol, specifically high LDL or low HDL, tobacco use, diabetes, hypertension, physical inactivity or obesity, as well as a family history of premature cardiovascular disease. And that is cardiovascular disease occurring in men before the age of 55 or in women before the age of 65. But there are other cardiovascular risk factors that are unique to women. And so that's why I included this particular slide. So here we have the traditional risk factors that I've already mentioned, but there are some female specific risk factors here, such as premature menopause or menopause hormone therapy, polycystic ovarian disease, and then some other risk factors unique to women that occur during specific times of their lifestyle during pregnancy. So the development of adverse pregnancy outcomes, such as eclampsia, preeclampsia, or gestational diabetes. So with that background about what traditional risk factors are and then some female specific risk factors, you notice I didn't add lipoprotein little a to that, but it is a risk factor for cardiovascular disease. And we're going to talk about that a little bit more in depth. So to the left here, you see that this is an LDL cholesterol particle. And on the right of the screen is lipoprotein A. And you can see they look very much alike, very similar. And the only difference is that the lipoprotein little a molecule has an apolipoprotein A component attached to it. Otherwise, it looks exactly the same as LDL cholesterol. And it's this apolipoprotein A component that confers the cardiovascular risk and the adverse outcomes that we see in patients who have elevated lipoprotein A. Traditionally, we have 2 different cutoffs for LP little a. Below 30 is considered normal or desirable. If you're measuring it not in mass, but in particle numbers, it's greater than 70 nanomoles. And then for those who have lipoprotein A levels greater than 50 milligrams per deciliter or greater than 125 nanomoles, that is considered at high risk. And it's this cutoff that we use to identify individuals who are at elevated risk for cardiovascular disease. So what do we know about the general population and the prevalence of LP little a? Well, it's not uncommon at all. 1 in 5 individuals worldwide and in the United States have elevated LP little a. So that's about 1.4 billion individuals in this world who have elevated LP little a. 80 to 90% of our LP little a levels is determined by a single gene. And so there's not a lot that can be done outside of that or that impacts our LP little a levels. But there are a few things that can impact that. But generally, what your LP little a level is determined at a very early age. We know that full expression of LP little a tends to occur by age 5. But there is some data from a paper in 2022 that demonstrated that LP little a can continue to increase after age 8. And so those authors suggested that for adolescents and children who have been tested for LP little a, if it was normal, that you may consider retesting again once they reach adulthood. And I mentioned here, diet and lifestyle changes have little impact on LP little a levels. We do notice that there is some variability with LP little a levels based on race and ethnicity. African Americans have 2 to 3-fold higher average Lp(a) levels relative to whites. We're not really entirely sure why, but we suspect that there's a geographic migration of Lp(a) gene out of Africa that actually is contributing to those high levels. The MESA study showed that Lp(a) greater than 30 milligrams per deciliter predicted increased coronary risk in Blacks, while Lp(a) greater than 50 milligrams per deciliter predicted higher risk for cardiovascular disease in whites, Hispanics, and Chinese Americans. Despite the different cutoffs in association with cardiovascular risk, at least in this particular study, our subsequent studies have shown no difference in coronary heart disease risk between Blacks and whites, irrespective of the Lp(a) cutoff point that is used. And so for that reason, for everyone, we really say that Lp(a) levels greater than 50 milligrams per deciliter is associated with increased risk for cardiovascular disease. As I mentioned, so 1 in 5 individuals has an elevated Lp(a). And it's important that we talk about this because it has significant public health impact. 1 in 14 heart attacks and 1 in 7 cases of aortic valve disease is associated with Lp(a). And so it is important that we're identifying individuals who may have high Lp(a) so that we can treat them, screen them for other cardiovascular disease risk factors, and treat them appropriately. Current recommendations, this is from the National Lipid Association, recommend measuring Lp(a) at least once in all adults and in selected high-risk children. And so those are children of a family member who has, a parent rather, who has elevated Lp(a), or a child who has familial hypercholesterolemia, because 30 to 50% of individuals who have FH also will have elevated Lp(a). How should we approach the management of individuals with elevated Lp(a)? Well, for those who are considered high risk based on that Lp(a) level, there are a number of things that we can do. Even though at this time there are no FDA-approved medications to help lower Lp(a), we do have several things in our armamentarium that we can do to lower an individual's cardiovascular risk. So first of all, once we identify someone as having elevated Lp(a), we need to be focusing on modifying those risk factors for cardiovascular disease. So if you have hypertension, if you have diabetes, we need to be making sure that your blood pressure is controlled through lifestyle modification and pharmaceutical therapy if needed, as well as your glucose, making sure your diabetes is well controlled. If you're a smoker, you need to stop smoking. If you're overweight, we would recommend losing weight in order to modify your cardiovascular risk. Another recommendation is once we identify an individual with elevated Lp(a), we really recommend cascade screening. And that means all first-degree relatives of the affected individual should also undergo testing for elevated Lp(a) because of the genetic inheritance of Lp(a). I talked a little bit about lifestyle modification, weight loss, exercise, and quitting tobacco. And there are certain therapies that can help lower LDL cholesterol that we should be prescribing for our patients if they have elevated Lp(a) and their LDL cholesterol is high. Because we know, independent of Lp(a), that LDL cholesterol, when elevated, is also associated with cardiovascular risk. I included this slide here because although I said 80 to 90% of Lp(a) is already genetically predetermined, there are a few conditions and states that can impact lipoprotein A levels. As you can see here from this arrow, menopause is one that is associated with increasing Lp(a) levels, and that is where we're going to transition to the second part of the talk. We do see that during reproductive years, Lp(a) levels can generally stabilize, but then surge during pregnancy. But that's just a finite period of time in a woman's lifespan. However, when women transition to menopause, you see here from the green arrow that there's a significant increase in Lp(a) levels that is being driven by hormonal shifts that can be associated with an increased risk for cardiovascular disease in a woman who, prior to transition to menopause, may have been at a lower risk for cardiovascular disease. Now, the woman who already had elevated Lp(a) in the premenopausal state We should have been focusing on modifying her risk and treating all traditional risk factors even before she transitioned to menopause. So we may not necessarily need to retest this woman because we've already identified that she has elevated LP little a. But for the individuals who are in that gray zone between 30 and 49, it may be worthwhile retesting them as they transition to menopause because their cardiac risk may have changed. So now I want to talk about menopause. And in looking at the slide, I'm sure many of you can identify some of the symptoms that you have personally felt or have talked to relatives who feel like they are any one of the women in this image here. So menopause, on average, occurs at the age of 51. The range can be anywhere from 45 to 55 years old. It is defined as 12 consecutive months without a menstrual cycle. And so if you've gone 11 months and 3 weeks and you get your menstrual period, you're starting over again because you haven't really transitioned to menopause. You may be perimenopausal, especially as we see periods when there are changes and inconsistency in the menstrual cycle. But it has to be a full 12 consecutive months without a menstrual cycle for us to really definitively say that you are in menopause. It is genetically predetermined based by age and also maternal history. And so I always ask my patients if they're unsure when they may be going through menopause, especially if they're perimenopausal, they may have some menopausal symptoms. They can ask their parent when they went through menopause, because that is likely going to predict when they themselves might go through menopause. Early menopause is when it occurs between the ages of 40 to 45 years old. And then there's premature menopause, and that's when menopause occurs before the age of 40. Both premature or early menopause can occur spontaneously, or it can occur as a result of surgery. So if you have a total hysterectomy or just removal of the ovaries without the removal of the uterus, sometimes radiation to the pelvic area, or even certain chemotherapies to treat cancer can push a woman into premature or early menopause. So regardless of the timeline, once you haven't had a period for 12 months, you are officially in menopause. The most common symptoms that women will complain or report to their clinician are vasomotor symptoms. And that essentially are hot flashes or night sweats, depending on the time of day that the symptoms occur. About 80% of women will report vasomotor symptoms. The challenging part for the women experiencing vasomotor symptoms is that they can occur for 10 years, actually, with a longer duration occurring in women who begin menopause that transition much earlier in life. So they can go even longer. I've heard of some women 20, 25 years still experiencing vasomotor symptoms. And although it's not your typical chest pain or shortness of breath like I see in my cardiovascular patients, vasomotor symptoms are quite debilitating. Women who experience hot flashes or night sweats report a negative impact on their quality of life. They're irritable, they can't sleep, they're waking up multiple times in the middle of the night. They report cognitive changes, so they can't think clearly, they're maybe a little bit forgetful, and difficulty concentrating. Compared with women who experience menopause at an early or the average age of 51, women who experience menopause prematurely or early, so before the age of 40, tend to have more severe vasomotor symptoms. So it lasts longer, and the symptoms, unfortunately, can be much more severe. And so you can understand why a woman experiencing vasomotor symptoms may go to seek some assistance on how to manage it, because this is on average about 10 years of sometimes nightly symptoms, and if not nightly, at least several days a week that women are experiencing these symptoms. So it really doesn't take long for it to become quite debilitating and affect your overall life status. There are some associated findings with the transition into menopause. We find that during that transition into menopause, there's more of an atherogenic lipid profile. So what does that mean? We see that women will tend to have higher levels of total cholesterol, triglycerides, LDL, but lower levels of the good cholesterol, HDL. And it's this type of lipid profile that is actually associated with increased risk for cardiovascular disease. The transition to menopause, as most women on this webinar can probably attest to, is that there's an increased likelihood of developing more weight gain, especially fat around the abdomen, loss of skeletal mass, and increased fat mass as well. There's also the development of the metabolic syndrome, and that's due to the negative effects on blood pressure, blood glucose control, the abdominal obesity I mentioned, and the weight gain. So as you can see, menopause, that transition and fully going into the menopause state represents a very vulnerable period in a woman's life cycle where we need to pay attention to associated risks for cardiovascular disease. And it's an opportunity for careful consideration for the symptomatic woman of thinking about the use of menopausal hormone therapy. Aside from vasomotor symptoms, the other symptoms that I will be talking about shortly will be the urogenital symptoms, and that is very common, especially as women age. What are some of the benefits of menopausal hormone therapy? Well, it provides relief from the hot flashes and the night sweats, reduces the risk of fractures and bone loss, addresses genitourinary symptoms when it is used locally, so intravaginal use of estrogen, and overall improves one's quality of life. FDA-approved indications for menopausal hormone therapy at this time include the treatments of vasomotor symptoms, as I've already suggested, treatments of genitourinary syndrome of menopause, preventing osteoporosis, and for the woman who underwent surgical menopause, especially prematurely or early menopause, estrogen replacement in this setting is also recommended. It is, however, not recommended for the primary or secondary prevention of cardiovascular disease. And that is important for us to note. So I'm going to go through a couple of studies that resulted in the use of menopausal hormone therapy, and then some of the studies that also changed the landscape of our use of menopausal hormone therapy. So the first study was a randomized trial of estrogen plus progesterone in women who had coronary heart disease. And in this particular study, the HERS trial, they were looking to assess whether it would reduce the use of menopausal hormone therapy, would reduce the risk of another cardiac event. So they enrolled about 2,800 women, younger than the age of 80. Average age was about 67. And they randomized them to either estrogen plus progestin or just placebo. And in this study, as you can see here, there was no difference as far as cardiovascular events among the two groups. And so these results argued against the use of menopausal hormone therapy for secondary cardiovascular disease prevention. The Women's Health Initiative was another study that randomized patients to, this is the primary prevention group of women with estrogen plus progesterone versus placebo. Average age was 50 to 79, so again, younger than the age of 80. And here, women were followed for an average of 5 years. In this study, however, they ended the study prematurely because the Data Safety Monitoring Board recognized that there was increased risk for those who were randomized to estrogen plus progesterone versus those who were in the placebo group. What we found that what was important is when the women were given estrogen therapy. And so it is not strictly just the use of menopausal hormone therapy, but when a post hoc analysis was performed, they found that really the risk was tied to the age of onset of menopause and how far out from menopause menopausal hormone therapy was initiated. So as you can see here, among women who were older, 70 years and older, who were on menopausal hormone therapy, they actually had the highest risk of coronary heart disease. And it actually was lowest amongst women who were 60 years older or younger, or who were initiated on menopausal hormone therapy within 10 years from the onset of menopause. I'm going to skip over this one just in the interest of time. So I'm going to briefly go through types of menopausal hormone therapy. There's systemic menopausal hormone therapy, so using oral agents, transdermal formulations, compound hormone therapy, and vaginal estrogen therapy. Systemic estrogen therapy is indicated for women who have vasomotor symptoms. It's actually the most effective agent for managing vasomotor symptoms. Oral and transdermal estrogen formulations have similar efficacy when you use the lowest effective dose recommended. And what's really important is because women who have a uterus may be at increased risk of endometrial hyperplasia and cancer when you use estrogen therapy alone, a progesterone agent should also be prescribed if you're considering menopausal hormone therapy. Transdermal menopausal hormone therapy is actually carries a little bit of a lower risk for venous thrombotic events compared to oral menopausal hormone therapy. Although head-to-head trials have not been performed, randomized controlled trials, observational studies have shown lower rates when it comes to VTE with transdermal menopausal hormone therapy. What we do know is that there have been at least over 10 randomized controlled studies that looked at the use of transdermal menopausal hormone therapy compared to oral. And we see that the effect on lipid metabolism is actually less when we use transdermal menopausal hormone therapy compared to oral preparations. Among US women, the use of hormone therapy, about 1/3 of those are using compound hormone therapy, often marketed as bioidentical or natural hormone therapy. Compounded hormone therapies are not monitored for safety or approved by the FDA. There are some FDA-approved bioidentical hormone therapies, including oral, transdermal, and vaginal estradiol preparations, as well as oral and vaginal progesterone formulations that are available. But current guidelines and position statements indicate that FDA-approved menopausal hormone therapy is preferred to compounded hormone therapy. So when we are exploring what agents to use to manage our symptoms, we really should be focusing more on the FDA-approved menopausal hormone therapy because there's a lot more data and studies focused on those compared to synthetic hormone therapies. There just isn't the data with the compounded hormone therapies right now when it comes to cardiovascular outcomes. I mentioned I was going to talk a little bit about vaginal estrogen therapy. Unlike vasomotor symptoms, genitourinary symptoms of menopause do increase in prevalence as women get older. Vaginal dryness, recurrent vaginal infections are some of the symptoms that women will report. Low-dose vaginal estrogen therapy is minimally absorbed at the current recommended dosing and actually tends to mimic normal postmenopausal range of estrogen levels. And so this is an option for women for whom systemic hormone therapy may be contraindicated, such as those who have had either strokes, heart attacks, an estrogen-responsive uterine or breast cancer, or some sort of venous thromboembolic event, whether they've had a deep vein thrombosis in the leg or a pulmonary embolism. And so if the only symptom a woman has is the genitourinary symptoms, low-dose vaginal estrogen therapy currently is the most effective treatment for those genitourinary symptoms and is very helpful and is a much lower risk than the oral and transdermal preparation. So how do we determine who should be receiving menopausal hormone therapy? Well, the presence of cardiovascular risk factors alone does not preclude the use of menopausal hormone therapy, but it is something that we should take into account when we are assessing one's cardiovascular risk. And so for those who are at low risk of cardiovascular events with the use of hormone therapy, an example of that group are individuals who just recently went through menopause, so within the last 5 to 10 years, who don't have any risk factors for cardiovascular disease. So they don't have hypertension, they're not overweight, they're physically active, they haven't had a history of breast cancer. And when you calculate their 10-year risk, it's low. Those at high risk for use of menopausal hormone therapy are those, as you can imagine, who have had cardiovascular disease. Maybe they've had a stroke or a heart attack. They've had a clotting event. They've had breast cancer, especially an estrogen responsive breast cancer. Or overall, they're at increased cardiovascular risk when we use our current tools for estimating 10-year atherosclerotic cardiovascular risk. The majority of women that we will be facing in the medical community are going to be those who are at intermediate risk. About 80% of women who are above the age of 55 and are transitioning into menopause have at least one chronic medical condition. And so while it may be clear for the low risk and the high risk woman, those who are at intermediate risk, this is where we really need to have discussion between the patient and the clinician. And the shared decision-making process is especially important as we determine whether or not this individual is a candidate for menopausal hormone therapy and whether or not the benefit outweighs the risk in their case. This is a chart that I often use and pull up in my clinic when I'm talking to women about menopausal hormone therapy. And as you can see here, the first thing we need to do is A, assess their 10-year risk. You heard me talk about that. 10-year risk for ASCVD. And then we need to know how long it's been since they went into menopause. And so for the low risk woman, if you've gone through menopause within the past 5 to 10 years, it's probably acceptable and lower risk for this individual to go ahead and treat symptoms with menopausal hormone therapy. For the individual who's at high risk for ASCVD, regardless of when they went through menopause, but certainly if it's been more than 10 years, we really should be avoiding at least systemic hormone therapy. Again, if they only have vasomotor symptoms, we can use vaginal estrogen therapy. But if it's been less than 5 to 10 years and they have significant symptoms, then again, we need to have a discussion about alternative therapies. And there are some non-hormonal agents, such as SSRIs, et cetera, and some use even clonidine that can help to manage symptoms for women who have menopausal hormone therapy. I'll skip over this particular one just because we're running out of time and I want to make sure we have some time for questions. The newest FDA-approved agent here is what is known, the trade name is Veozah, but it's also Visolonitant. It's a non-hormonal medication for treatment of vasomotor symptoms that was approved in 2023. It's a neurokinin 3 receptor antagonist that's indicated for the treatment of moderate to severe vasomotor symptoms from menopause. In this study, they enrolled women who were aged 40 to 65 and had on average 7 or more moderate to severe hot flashes per day. They were randomized to placebo and different doses of the medication. And what they were looking for is the change in the frequency and severity of vasomotor symptoms at 1 month and again at 3 months. Compared to placebo, they found that regardless of the dose used, there was a significant reduction in the frequency of vasomotor symptoms at 1 month and at 3 months. And in fact, improvement occurred as early as 1 week from start of the medication and was sustained over a year. And so some of you may have seen this medication either online or on TV. And so this is an option for women who are not candidates for menopausal hormone therapy, but have moderate to severe vasomotor symptoms. So what do the national guidelines and medical societies say about who should use menopausal hormone therapy or when we should use it? We've already talked about the different categories, the high risk and the low risk patient. In general, the recommendations are that we use menopausal hormone therapy to treat menopausal symptoms. It's not to prevent cardiovascular disease. None of the current societies recommend the use of menopausal hormone therapy to prevent coronary heart disease. In general, the recommendation is to use the lowest effective dose to manage symptoms for the shortest period of time. And then to continue to reassess for women who are on menopausal hormone therapy as they age, whether they need to continue to be on the medication or whether they're no longer having symptoms. So I'll stop with this summary slide by just reviewing some of the things that we talked about today. I hope that I've been able to impress upon you that lipoprotein A is associated with increased cardiovascular risk. Lipoprotein A levels may increase in the postmenopausal stage of a woman's life. And so for the woman who had border lipoprotein A levels, it's worth considering cardiovascular risk assessment and retesting. I hope we all have a better understanding of menopausal hormone therapy use regarding timing, route, and those who may be considered to be at increased risk. Hormone therapy is appropriate for younger, healthy menopausal women who have lifestyle limiting, bothersome menopausal symptoms. And the transdermal agent is preferred to oral agents, especially those at high risk. So I'll stop there.
Thank you, Dr. Isiadinso. That was really wonderful. And I'm sure we have some questions. I'm not seeing any in the chat yet. So if anyone sees them in the chat, please let me know. Um,
Susan, there's one in the Q&A section. Is there a correlation with early menopause or premature menopause and high Lp(a)?
Sorry, I've got a dry throat there towards the end. Misty, can you go ahead and repeat that?
Sure. Is there a correlation with early menopause or premature menopause and high Lp(a)?
Certainly, I'm not sure about early menopause, but just in general, the transition to menopause. And it's really because of the hormonal changes that are associated with an increased risk for high Lp(a). So regardless of when a woman transitions, whether it's early on or the natural transition, like in their 50s, we should be retesting for elevated Lp(a) if it hasn't been done previously.
are there other questions? Oh, here's one. What kind of cardiac tests do you recommend for assessing a woman's risk?
That's a great question, Nicole. So I think first thing that should be done is there's some non-diagnostic tests that should be performed um, as part of the evaluation. So firstly, just to ensure that a woman's blood pressure is well controlled. And so this can start with primary care, but does not need to necessarily see a cardiologist for this type of evaluation. Making sure your blood pressure is controlled, making sure your glucose is controlled. We talked about smoking, helping you quit smoking if you are a smoker. For those who are physically inactive, making sure you're exercising. When patients come to my clinic, I always ask them every single visit what they're doing for exercise. And for me, it's not sufficient for them to share that I exercise. I want to know what you're doing because there may be room for improvement, whether it's increasing the frequency, intensity of exercise, and even the type of exercise that we're doing. And so typically, I will encourage women to participate in 150 minutes of some form of moderate intensity aerobic exercise, doing something that you love to do, and then a strength training at least twice a week. So that's part of the initial non-diagnostic assessment. Then there are some tools that can help us to assess one's cardiovascular risk. One great one is calcium scoring. So a calcium scan is a non-invasive CT scan that can scan the chest and look for evidence of calcified plaque. And depending on the amount of plaque that we see, we know that that actually does predict cardiovascular risk. And so for my patients, that can be quite informative about their risk if they have no other risk factors and all they have is elevated Lp(a).
We have another question here. The individual says that their LPA is 185, but not sure of the units, probably nanomoles per liter. And she is 54, perimenopausal, on an estradiol patch, 75, and progestin question mark, and 200 pill. I don't know what that pilly. Thoughts? She's asking, I don't know, her.
Yeah, I see the question in the chat. I'm not sure what 200 pill means, but I think the bottom line is, while I can't give anyone specific medical advice, right, because I'm not privy to your entire medical history, family history, and all of those things, regardless of the units of measurement for this lipoprotein A level, it's high. It's high. And so for someone who's already perimenopausal, I think this is the time where you want to have that discussion with your PCP and maybe a preventative cardiologist about the use of hormone replacement therapy. 'Cause I would assume for this 54-year-old that she may have just transitioned to menopause within those first 5 or so years. And so it would be worthwhile to understand other cardiovascular risk factors that may inform her overall cardiovascular risk.
Right. And this is just to remind everyone that Dr. Isiadinso can't give medical advice to you because you're not her patient. And that's why you need to go back to your own doctor. Next question. I am in gray zone LP little a. All other factors are normal. Do I have to take medicine if I have no family history?
Well, firstly, there are no medications specifically that are FDA approved that are available for lowering of Lp(a). So that's number one, whether it was high or not. But I think, one of your questions, should you take medications if you had any other medical problems such as high cholesterol? For those in the gray zone, that's the difficult part. And if this is someone who, if they were not menopausal, I probably would retest them when they transition to menopause since they're in the gray zone because I wonder if their LP little a level would become elevated. I think also this is an individual where, again, if they're in the gray zone, whether a calcium score may inform about their risk depending on their age, if they have no family history. But the medications wouldn't be specifically for LP little a, it would be to treat any of the known cardiovascular conditions that are associated with cardiovascular disease, like hypertension, diabetes, and high cholesterol.
Okay.
Susan, I was going to just tell you there's people asking questions in the Q&A section too. So maybe everyone before I posted that, if you could answer those, and then we can switch to the Q&A section to make sure everybody's getting answers.
Okay, so I'm going to finish here in this chat.
Yes, I think there were two more before I posted that, and then we can switch to the Q&A.
Okay. All right. The next one is the portfolio diet seems high in foods that can interfere with the absorption of iron. Any tips for women who tend toward iron deficiency, but who need a very heart healthy diet?
I have to be transparent. I'm not actually familiar with the portfolio diet. Um, Typically for cardiovascular disease risk reduction and for overall cardiovascular health and wellness, we recommend either the DASH diet, especially if one has a history of high blood pressure, or the Mediterranean diet. The Mediterranean diet is a balanced diet that is rich in fruits, vegetables, healthy fats like olive oil, ingesting avocado, and low in processed foods, sweets, and red meat. And so, in general, that is the diet that I recommend to my patients is the Mediterranean diet.
Dr. Isiadinso, I just Googled it really quick. It's a plant-based diet. So
Ah,
it's
okay.
replacing animal products with plant-based foods.
Yeah, well, I am a proponent of plant-based diets for sure. We know that not only is it good for overall health, lower risk of cancers, and I find it very helpful for my patients who have inflammatory rheumatic conditions as well. Shifting to a plant-based diet, they will at least report fewer incidences of flares and things like that, and fewer symptoms. Thanks for looking that up, Jen.
Sure.
The next question. I'm 52 and perimenopausal and just diagnosed with high LPA, 135 milligrams. I was diagnosed with lupus nephritis when I was 32. I just started Repatha. I am nervous about all of it. I started with higher blood pressure last fall. I exercise doing the elliptical and walking and light weightlifting and eat healthy for the most part. Any advice? I'm waking with panic attacks due to the recent LPA test. My calcium score was 0 last year.
So, first of all, I want to validate the way you feel, right? Is that your calcium score was 0, you're already someone who has lupus nephritis, and then you discover that your lipoprotein A level is high. And with a genetic component, one might feel, what can I do? So one of the things that, is we see that when women transition to menopause, blood pressure also becomes a higher. And so that is, I'm not surprised to see that you mentioned that you started with having high blood pressure last fall because this is sort of the transition into the menopausal state. And so you're doing a lot of the right things. You're exercising, you're weightlifting, you're eating healthy. So those are great. Those are the things within your control that you can do. And now you work with your clinician, so your PCP, your rheumatologist, to help manage your blood pressure first and foremost. We know that when you control the blood pressure, you reduce your risk for cardiovascular disease as well as renal complications. And then as far as lipoprotein A, although we don't have any medication specifically targeting LP little a, we can treat cholesterol, so LDL cholesterol, making sure that's low, and as I mentioned, the blood pressure. The calcium score at age 52, we're not entirely surprised that that can be low in a 52-year-old woman. And so that does not negate the fact that the lipoprotein A level is high and that there are risk factors that we should be modifying and treating.
Thank you. Next question. I am a 55-year-old on hormone replacement therapy, transdermal, which has been an amazing treatment plan to manage my symptoms. I run at least 4 miles, 4 to 5 days per week, and strength training about 3 to 4 days per week. I was recently diagnosed with elevated lipoprotein A, and my cardiologist prescribed 10 milligrams of statin and Repatha. I'm super uncomfortable with the Repatha. Oops. And I'm losing this question.
It looks like the physician then changed, instead of the Repatha, switched the current statin dose from 10 milligrams to 40 milligrams to gain additional LDL cholesterol lowering.
Okay. And she says she's otherwise a healthy woman with a super clean diet and exercise regimen. Her LPA is 167. Can you talk more about statins and Repatha?
Yeah. Well, statins we know are tried and true. They've been around for at least 30 years. The first medication, Mevacor, was FDA approved in the late 1980s. And so there's a lot of evidence about the efficacy and safety of statins. And so they are helpful medications to help lower cholesterol as well as reduce cardiovascular risk for those who are at high risk of cardiovascular disease if they've never had an event, and for those who have had a cardiovascular event. Repatha is another agent that was approved probably about 2018 or 2019, and it is really helpful at reducing LDL cholesterol by about 50 to 60%. It is also quite safe. Most of the side effects are really injection site side effects, such as redness, maybe arm soreness, and rarely somebody may have some runny nose from the use of Repatha. The dosing is also different. So statins are dosed every day. You take the medication versus the injectable medications, Repatha or Praluent, which are taken every 2 weeks. And the one other thing that we found in studies is while statins don't lower lipoprotein A, the Repatha or Praluent actually does by about 20 to 25%. And so sometimes I will use that in my patients who have elevated LDL cholesterol and Repatha.
Okay, our next question is, do we know when there will be an approved drug to reduce LP little a?
Yeah. Just in the interest of time, I didn't include the slide that I have that covers the different phase 3 cardiovascular outcomes trials that are investigating the use of lipoprotein A to reduce cardiovascular events. But the first study has already ended enrollment and is expected to release results early 2026. So that may be the first um, results that we have available to us about an a medication to reduce lipoprotein A. But in addition to the injectable medications, there are also oral medications that are in development and being studied for reducing lipoprotein A. So it's a very ripe and active area of investigation. And I anticipate that we probably will have an agent available within 3 to 5 years, just based on the way the speed of the research is going and the interest in finding an agent to reduce this one risk factor that we don't that is non-modifiable.
The next individual is stating that my LP little a is 330 and my LDL is 169. My HDL and triglycerides are within the normal range, and I'm 50 and perimenopausal, trying to figure out if I need medication now.
Susan, I'm going to stop you really quickly, though. Whenever Dr. Isiadinso finishes this question, if we can switch to the Q&A section, we have a lot over there that were there before these in the comments
Okay,
now.
very good. And then we'll come back to this.
Yeah,
Perfect.
sorry.
Okay. That's okay.
Sure. I think this is a situation, again, an LDL cholesterol of 169 is certainly high. And so this is a situation where I would recommend that this woman speak to her clinician to talk about medications to help reduce her cardiovascular risk and treat her cholesterol. And there are clinical trials that patients can enroll in. Now, obviously, you may get randomized to placebo, but you may also get randomized to one of the study drugs. And these study drugs, on average, depending on the particular study, are lowering lipoprotein A anywhere from 80% to 95%. We can switch over to the Q&A.
Yes, I'm switching over. I'm reading, Misty, did we read the first one already, or do we not do that one?
No, you
Is
can go ahead with that one,
okay.
that first one.
Is high LPA considered a CVD risk factor that would discourage prescribing MHT?
That's a great question, and I face this with my patients quite often. I don't feel like it is a CV risk factor in and of by itself that would preclude the use of menopausal hormone therapy. You really take the entire patient and their clinical history into consideration, right? And so having diabetes, which we know is a CVD risk factor, having that alone would not preclude me from using it. These are individuals who fall in that intermediate range, as I was discussing. So this is where you talk about a risk-benefit ratio about the use of menopausal hormone therapy, the severity of symptoms, the indications for use, and what other clinical conditions the patient may have that will also affect their cardiovascular risk.
Okay, thank you. Next question. My LPA is 368 and I'm 43. I'm very concerned. Both my parents also have high LPA, but not near as high as mine.
Yeah. And so this is the situation where this patient or Talia would benefit from meeting with a preventative cardiologist, right? Because you try to understand what risk factors you have that you can treat now until the medication becomes available. And I think one thing I want to just touch on, because this has come up once before in the chat, is just the fear and the concern. And I understand that. And it's because there's nothing you did to have high lipoprotein A levels. You didn't eat your way to it. It's not like you were smoking and had high lipoprotein A. And because at this current time, there's not a specific medication that is FDA approved to lower it. Now, there are other therapies. If somebody has had a cardiac event and their lipoprotein A is high, there's something called lipoprotein apheresis that a patient may be a candidate for, but that's in very specific circumstances. And so I understand the fear of living with a condition or being told you have a high level and being unsure what you can do, maybe feeling like your hands are tied or you're left up to fate. But I always tell my patients, just like a calcium scan, if you find out you have elevated coronary calcium, it's the same as if you found out that you had high lipoprotein A. This is an opportunity to make some significant lifestyle changes and to treat the risk factors we know that exist. So if your blood pressure was slightly elevated and we've been, quote, watching it for some time, this is the time to take that step and treat the blood pressure. This is the time to start exercising, to quit smoking. So there are some things within the control. So I don't want your audience to walk away with this sense of fear and anxiety and staying up all night. And I've heard that even from my patients, just worrying that something is going to happen tomorrow. There are things that we can do, and eventually, I'm sure that there will be an agent available.
Our next question, I have CVD, 30% plaque in most major heart arteries, but no events. I am 50 years old. I have a lot of joint pain, bloating, and sleep issues. My LPA is 258 nanomoles per liter, so HRT, even transdermal, is not recommended.
Yeah, I think again, this is one where this person needs to have a thorough discussion with their cardiologist about the use of menopausal hormone therapy. They have some atherosclerotic disease. They haven't quite had an event. Um, she has high lipoprotein A, and it sounds like is having some menopausal symptoms, no vasomotor symptoms, but maybe some sleep issues, which may or may not be tied to menopause. It's unclear. The bloating, I'm not sure I can tie that to menopause. It's not mentioning that there's abdominal obesity specifically, the weight changes, et cetera, or vaginal symptoms. But again, this is somebody who needs to speak with their cardiologist specifically about their risk, knowing that they have some coronary artery disease and whether a transdermal is an option. When used in those people who have intermediate risk, I really will recommend the transdermal route for their estrogen delivery and not the oral because the transdermal is lower risk for cardiac events.
Our next question, do you find that SSRIs like Paxil give good results for menopause symptoms?
Yeah, I have seen that used for women who are having menopausal symptoms, especially because it also targets some of the anxiety and the insomnia that occurs with menopause. And so a lot of primary care physicians will actually use SSRIs for treating menopausal symptoms, especially in the patient who is too high risk for the use of menopausal hormone therapy.
And then similarly to an earlier question, what do you see as the future for LP little a considering present clinical trials? Is there hope for a pharmaceutical treatment in the near future for women?
Well, there's hope for a pharmaceutical treatment for all, not just for women, and that's the exciting thing. Is I think last counts that I'm aware of, there may be 5 or 6 different studies ongoing. One that has, as I mentioned, has already ended, and the other 4 or 5 are ongoing. And there is great interest. There really is. And in fact, there's actually now most of the studies are looking at individuals who've had cardiac events, cardiovascular events, and that's understandable because that's the highest risk group. So if you're worried about elevated LP little a, which is associated with cardiovascular disease, the first group that you want to identify and treat to see if you can reduce events is in those who've had events, so they don't have another event. But there's actually a newer study called Ocean A Prevent, which is looking at patients who are at increased risk for cardiovascular disease, but have not had a cardiovascular event and have high LP little a levels. And I'm happy that they're looking at that group because my concern has always been, great, we'll finally find something to prescribe for patients who have high LP little a and have had a cardiovascular event. But what about the rest of the population who hasn't had an event, right? How do we treat them and prevent them from having that first event? So that's exciting that is actually now a study that is ongoing.
Right. That's a great thought, about all the other people, right?
Yeah,
Because
yeah,
there's a lot of us that are in that category.
that's right. 1 in 5.
So our next question is my LP little a dropped by 100 nanomoles, mid 300s to mid 200s between a summertime test and just a couple of weeks ago. I started HRT during this time, hit it hit a year of no periods, and I was already 6 months into Repatha at the summertime test. Do you think the LPA improvement is the HRT?
Well, it may also be the Repatha, to be quite honest with you. I'm not sure what the number was, if one of these numbers was on Repatha, but pre-HRT. But to answer the question, yes, estrogen hormone therapy can reduce lipoprotein A levels.
Okay, our next question is a very common question that we see. I know we are told to take LPA readings once, but if treating on Repatha and statins, should it be retested again to see if it's having any effect?
So that's an interesting question. Should it be retested? It doesn't have to be retested. I often don't do it simply because I know what the expected reduction in lipoprotein A is. And especially if the person was very high, if we take an example of somebody whose lipoprotein A level was maybe 200, if I get a 20 to 25% reduction, maybe I'm 160 milligrams per deciliter. It's still high. It's done the best that it can do. And statins have an opposite effect on lipoprotein A, but they're so beneficial in preventing cardiovascular events and treating and preventing a second event in somebody who's had a first event. So the current guidelines don't recommend retesting after prescribing a medication. Have I done it in the past? Yes. Some patients are curious to see what their level is after being on treatment. So, we do it. It doesn't change the management, right? You don't adjust the dose of the Repatha or Praluent based on the lipoprotein A level. You don't stop a statin if the lipoprotein A level goes up 10 to 20%. And so it's not necessary. Some people may do it just out of curiosity.
I'd like to just go back to the other list for 1 second because I know the person who asked this question. Is it possible that the risks may be even higher in African, Afro-Caribbean populations due to lack of screening for Lp(a)? If there is a detection bias and we have a significant family history of cardiovascular disease, should we just push to get approval for the test?
I'm not sure if we can ask Jessica, what does she mean by, is it possible that the risk may be even higher? What risks?
I think she means for Lp(a). Let's see, do this.
Because thus far, the higher lipoprotein A levels that is seen in Blacks has not translated to higher cardiovascular risk. I will say that overall, lipoprotein A testing in the US population is very low. Less than 1% of individuals with high lipoprotein A have even been identified. And so we need to do a better job in increasing awareness, which is what your wonderful organization, the Family Heart Foundation, does, increasing testing as well, and talking to underrepresented communities about testing and screening, and more importantly, cascade screening. I found that sometimes one may know that they have elevated lipoprotein A, but no one else in the family does. And I always say to my patients, we want to make sure we empower all family members to take that first step and take preventative measures and incorporate strategies to reduce their risk when they find out. But they'll never have the opportunity to do that if they don't know that they should get tested.
And Jessica did put in there that the screening seems to be more routine in
Yes.
Europe. However, I'm not so sure that's true. I think that's a perception that we have.
No, she's actually right. So
Okay.
Canadian Society and European Society for Cardiology do recommend lipoprotein A testing at least once in a lifetime. The US historically has not done that. Previously, they recommended lipoprotein A testing in high risk populations. So people who have had recurrent cardiovascular events, if they have FH, if there's a family member who has high lipoprotein A, if for some reason the LDL cholesterol is not dropping as expected in response to the appropriate dose of statin or lipid lowering therapy, or for those who have or at high cardiovascular risk. But from the National Lipid Association, their recommendation as I showed in that slide in 2020, I think it was 2021, that document that lipoprotein A testing should now be done in all individuals at least once in their lifetime.
Do we have time for a couple of more questions, or are we out of time here?
Yeah, out of respect for everyone's time, I hate to keep doing that. And then I don't know, we'll find a stopping point either. Jen did put in the chat an email address that if you guys want to send your questions to, we can try to get those answered for you. And I have written down all the ones that we did not get to tonight, so I can try to get those answered and posted on Facebook in our group as well.
That's great. Thank you,
That's a great
Misty.
idea.
And
That's a great.
can I just ask one quick question? Because I don't know if this is one that we could answer necessarily. A link between endometriosis and heart health. So she has high LP little a, it's 240. She's been in and out of menopause since 2016 because of endometriosis and hysterectomy. And now she's started on rosuvastatin. She can no longer take HRT due to the endometriosis flaring up. And she just had surgery in August for endometriosis. So she has started on paroxetine, and it's not helped with her hot flashes
Mhm.
and night sweats.
Yeah.
And her LDL did elevate after stopping HRT.
Mhm.
Is there a link between I do hear a lot about endometriosis and um, LP little a, or I don't know. Has anybody studied that?
I don't know if anyone has specifically looked into that. I'm not aware of an association between specifically endometriosis and elevated LP little a. So, but endometriosis is one of those conditions that women do struggle with. It does take years before a diagnosis is finally reached. She's had a hysterectomy. I'm sorry, you may have mentioned her age, but she's young enough that she
She's mid 54.
54, okay.
Mhm.
So she's undergone surgical menopause at this point, right? And is on menopausal
Mhm.
hormone therapy. And, it sounds like certainly she tried a non-hormonal agent, right? Because prior to the hysterectomy, that would have caused worsening of her symptoms, and that didn't help. So I think this is one of the things where menopausal hormone therapy may be the avenue that she has to pursue. I don't know the rest of her cardiovascular risk factors, of course, but there's also the non-hormonal therapy, the newer agents, as I mentioned, that has been shown for women right in that age group where she is, who have significant vasomotor symptoms, which is what she's reporting, and they had a good response. So that may be another
Mm.
option.
That might be a good one to talk to her doctor about.
Yeah.
Thank
Well, I
you.
want to really thank all of you. And I particularly also want to thank Jen Farnell, who's the Director of Community Engagement, and Misty Votaw, who is an Associate for Community Engagement, for your support and wonderful assistance technically in getting this going. And obviously, Dr. Isiadinso, you are full of information, and we really need to get you back again so we can talk about postmenopausal women and all the other things that we didn't get to tonight. So hopefully you'll be amenable to coming back and talking to our group another time. And we thank you so much for tonight.
Yes. Thank you, Dr.
Thank
Isiadinso, and thank
you.
you, Susan.
Thank you very
Thank you,
much.
Susan.
I really
Thank you,
appreciate
Dr.
it.
Cienzo.
Thank
Thank you, everyone.
Thank you again for coming.